Hello everyone, this is an update of a study for exudative AMD, follow-up 8 years. We use a combined treatment with an anti-VEGF IVT and a subtenon corticosteroid injection done at the same time. Purpose was to treat difficult cases of CNV with resistance or tachyphylaxis. With time, always quite some results observed. First, we use triamcinolone for the corticoid subtenon injection, but because of intraocular pressure issues, we mainly use betamethasone till 6 years. Delay between 2 injections is more than 3 months for 70% of patients. Mean delay about 5 months. For functional result with Snellen acuity charts, 70 to 76% of patients stabilize or improve, 24 to 30% decrease. For patients with bad result, we switch to Eylea, as you will see next. These patients are those who had visual acuity decrease even with use of combined Lucentis and corticoids. Follow-up, 4 years. Switch to Eylea alone, successful for majority of patients, but more than 35% develop resistance or no response with Eylea. For these cases, we use combined treatment, majority with betamethasone, as you can see. Mean delay between 2 combined injections was more than 3 months with betamethasone, 4 months with triamcinolone. For functional results, almost 14% of patients improved, around 70% stabilized, but some decreased with atrophy of fibrosis. See some lessons. We did corticoid injection in subconjunctival space for more than 1 year, no more in subtenon. Same results and no change compared to subtenon. It's quicker and easier. Combined treatment is cheap and effective. With time, number of patients with resistance to anti-VEGF increased a lot. For Lucentis, almost 170 eyes more developed resistance in 1 year. For Eylea, last year 70% of patients had resistance, now the double. Previously, we thought that after starting a combined treatment, it was impossible to go back to anti-VEGF IVT alone. It's no more true. 5 patients became eligible to anti-VEGF IVT alone without need to use corticosteroids. It could be related to anti-VEGF receptors reactivation if CNV didn't have had recurrence for a long time, or the pericyte barrier no more active and possible better penetration of anti-VEGF. We don't know. So, take-home message. Don't forget corticoids if you don't want to treat your patient too many times, or if they have resistance to anti-VEGF alone. Thank you very much.
Thank you for your presentation. I have a couple of questions if the audience has some. My first question is, could you please define resistance to anti-VEGF?
Yeah, resistance, it was when a patient had necessity to have a monthly treatment, or if they have no response with anti-VEGF, or if they have visual acuity decrease.
So how many injections do you wait until to define resistance?
Not so much with time, because we have good results with combined treatment. So we switch very quickly.
So say 3 or something?
For a patient, we never did 3 injections for induction treatment, never. And because of that, we think that we have good results because we don't have problem with receptors. We think that the more you do injection, the more you have resistance. I think so.
Do you have any other questions? I have another question. How much time do you separate the 2 injections? Do you fight combined injection at the same time, or do you?
It's both at the same time. It's just, for example, you do your IVT at the temporal site up, and you do the subtenon or subconjunctival at the nasal inferior. Just very
so the
simple.
same time. You do that same time.
Yeah. Same day, same times.